but it's a tumor of the squam cell, and it is a benign tumor. So this is a acoustic tumor. See, this is the internal auditory meatus, and these are the vestibulocochlear nerves and facial nerve. So acoustic neuroma is seen in the lateral part of the internal auditory meatus. This place is also called as cerebellopontine angle. This is the ring and pons. So there are three variants, three types called vestibular schwannoma, also called as cerebellopontine angle tumor, is also called as acoustic neuroma. Etiology is usually not known, maybe because of defect in the 22q part of the chromosome. And there are two types of histopathology, type A, type B Anthony cells. Type A Anthony cells are closely packed spindle cells and vertebrate bodies are present, whereas type B are loosely packed and vacuolated cells. So pathophysiology is, as I told you, it's a benign tumor. It doesn't invade the surrounding structures, but it causes pressure over the surrounding structures. And even the bone of the external aortic canal is eroded. Moreover, it is called as resorption than erosion because it is slow progressive erosion because of increased vascularity and fibrosis surrounding the bone structures, but not actual invasion. Symptoms depending on the structure which is involved. So initially, this is the internal auditory meatus, and this is the cerebellopontine angle. This is the cerebellum. So first, as it starts from the vestibular nerve, initially the patient presents with vertigo and tinnitus. As it involves the cochlear nerve, then the patient will be having high frequency hearing loss, and it further enlarges, and now it compresses the seventh nerve, facial nerve. So whenever a nerve is involved, first the sensory segments, sensory fibers get involved. So facial nerve supplies the sensory part in the external auditory canal. So sensation of that part is lost, and that is known as Hesselberger sign. It is the loss of the posterior and superior part of the external auditory canal, which is supplied by the facial nerve. And later, if the muscular component is also involved, then it leads to spasms and facial nerve. And further, if it is enlarges furthermore and it compresses the cerebellum in this way, this results in a disequilibrium. If it is further enlarges, now it goes near the trigeminal nerve, fifth nerve. This results in a midfacial hyperesthesia and corneal hyperesthesia. Mostly the sensory nerves are first involved. And further, it can compress the brainstem. So on compression of brainstem, the patient will be having headache and other cranial nerve palsies. Further, it compresses the aqueduct too. If the aqueduct is involved, then the patient will be having hydrocephalus, visual loss, and limb weakness. The main investigation involves MRI is a gold standard, and CT can be done to identify the bone erosion. Basing on the investigations, it is divided by Jackler staging, basing on only the extrameatal part. We are not counting the intrameatal part, the part which is outside the meatus. Basing on the size of that, it is divided into 5 grades. Grade 1, which is small, which is 1 to 10 mm, and grade 2 is medium, 11 to 20 mm. Grade 3, moderately large, 21 to 30 mm. Grade 4, large, 3 to 4 centimeters. And grade 5 is more than 4 centimeters. So basing on the tumor size, the approach of surgery is decided. Cystic vestibular schwannoma and medial vestibular schwannoma are variants. Usually the schwannoma occurs in the lateral part, but a variant known as medial vestibular schwannoma is also present. So treatment, if it is slow, a small one is slow growing, usually observation is done, but the surgical excision is a treatment of choice. And gamma knife surgery is an alternative treatment of choice. So for surgical excision, there are different types of approaches: translabyrinthine approach, middle craniofossa approach, and retrosigmoid approach. So disadvantages of translabyrinthine approach is it destroys the residual hearing, and there are chances of serious fistula formation. The advantages are there is no cerebellar retraction, and facial nerve grafting can be done. The advantage of translabyrinthine involvement is we can go via the labyrinth, via the external artery meatus to the middle ear to the labyrinth, and then we can reach the tumor through the internal artery meatus. Whatever be the size of the tumor, we can remove the tumor by this method. But in the way, we are destroying the labyrinth as well as the middle ear, so that we are destroying the residual hearing capacity of the particular ear. Another approach is middle cranial fossa approach. By this, we are avoiding damage to labyrinthine, but by retracting the cerebrum. So by retracting the cerebrum in this way, by a middle cranial approach, we can approach the tumor. But it is limited to the size of the tumor. Large tumors cannot be removed in this way. So disadvantage is temporal lobe is retracted and the size is limited, and the facial lobe is also at risk because we cannot reconstruct through this procedure. Another is retrosigmoid approach. The advantages are hearing is preserved because here also we are not destroying the labyrinth. But the disadvantages are here also we retract the cerebellar, and diffuse facial nerve grafting is very difficult, and postoperative headache as we are entering the cranial cavity. Another technique is by gamma knife stereotactic radiosurgery. This is an advanced procedure. When the size of the tumor is smaller, we can opt for gamma knife radiosurgery. Thank you.